myopia, something that is, something that is really a major cause for concern for all of us. I think we have Dr. Meenakshi now all set for her talk. She'll be talking on identifying high-risk children, prediction and preventing myopia. So we'll start with the talk, and maybe we'll, if we get time for discussion, we'll do that in the end. So Dr. Meenakshi, please.
Thank you, Dr. Rohit. A very good afternoon to all of you, and thank you, Scientific Committee, for asking me to speak on this. The topic is identifying high-risk children, prediction, and preventing myopia. The only great thing about this topic is at least I'm not speaking on progression, because that will not finish in 7 minutes. Probably needs a whole day. So most of us know this. When we talk of high-risk children, we know this. This is Knobloch syndrome, CSNB, Marfan syndrome. So a syndromic patient who is generally known to have myopia will usually have myopia, and so you have to screen for that. But aside from that, we are talking of children who may develop progressive myopia, that too, high myopia. So those of us, pretty much all of us are in practice, and in private practice you'll get cases like this. And the more senior you become, the more you get patients like this. A doctor couple has come to your clinic with 3-year-old son. Father wears a -1.5. Mother used to be a -7 myope, but had LASIK done. They want to know what are the chances that the child will develop myopia. Or neither parent has myopia. First child has been discovered to have myopia at age 7, who's also your patient. They want to know what are the chances of the second child developing the same, and at what age to test him. He is now 3. So really, why are we even bothered? Is it really that bad? Myopia is such a big problem? Of course. In East Asia, 80 to 90% of 18-year-olds are myopic. And 10 to 20% of these are highly myopic. The predicted prevalence by 2050 that there will be 4,758 million people with myopia, and a considerable number of these with high myopia globally. And let's look at North Indian myopia study. Dr. Rohit is here, who is the lead investigator on this. Large cohort, prevalence is 13%, higher in private schools, higher socioeconomic status, those with lesser time outdoors and more with increased screen time. And so, yes, it's a significant problem in India as well. So we're going to talk about myopia prediction first. And really, when you talk about prediction, you want to look at it scientifically, you have to look at data-driven myopia prediction. And then this falls into baseline refraction or biometric data, genetic data, or lifestyle data, or integrated data. I'm just going to touch upon this. So look at this. From 1999, that's how long we have known this, that the baseline spherical equivalent is a single best predictor for myopia onset. When you define it as -0.75, which was what the original definition was, and you add parental myopia to this mix, then the sensitivity and specificity becomes even higher. But preceding change is the best predictor of progression. So thoughts I'm going to leave you with. Many of these studies have been done in very specific populations. Can you extrapolate and apply these models to older and younger children? Like the 3-year-old that the parent brought. Can you apply them to other or mixed ethnic populations? Because many of these were done in East Asian populations. What about prediction based on lifestyle? Many papers talked about more near work, more myopia. Less time outdoors, more myopia. And so there was something called cram schools, kind of like our board exams, students. They all had higher myopia. But the OLSM, the Orinda longitudinal study of myopia, definitely said, adding lifestyle to this mix improves the prediction. The Generation R study, which came out of Rotterdam, other than all the other factors, also talked about less time spent outdoors, and no participation in sports were very important predictors of myopia. But look at this. For every paper that shows there is this, prediction, there'll be something that will say, equal number of studies will say, there is limited improvement in prediction. So we basically need more studies. What about genetic data? One myopic parent, 14.9%, 2.08-fold increase in risk. Two myopic parents, 43%, and the risk increases 5-fold. So we all know that there is gene, environment, interaction, and the most important thing is the patient comes to you with a higher genetic load, and then the higher education, the near work, is it just increasing the risk of developing myopia? So, okay, moving on to prevention. We all have been talking non-stop about outdoor time. Sydney myopia study looked at 2 hours. That's a really long time. And the Guangzhou study, which was an interventional study, put one group for 40 minutes of outdoor and one group just stayed indoors, and they looked at these kids for onset of myopia. There was a significant difference in those who went outdoors. Taiwan, all right, they tried everything. Improving room lighting, table height, encouraging distance gaze, ocular exercises. I don't know, what is this, 39 minutes intervals, but followed by 10 minutes break. They tried everything. Nothing happened. But after the education policy said, we are going to introduce 80 minutes per day, then they dropped from 17 to 8%. So all this is more important, more effective before the onset of myopia. So practice Pearl, increase outdoor sunlight time. We don't always have access to grounds but make sure there is something, sports, balcony, terrace, park, beach, somewhere the child gets outdoors. Talk to your child's school, ask the parents to speak in the PTA, not to cut out the PT period, which is what happens in most of the schools, and they have extra classes in those. And moving on to education and near work. Yes, higher IQ, more number of school years, after school tuition, all this definitely had higher incidence and prevalence. Less intense curriculum. If you have both parents myopic and the child has already started to become myopic at age 3, try and see if you can move the child to a less intense curriculum, less online extra classes, tuitions, competitive career exams. And then if you look at SMS and SCORM study, they talked about various types. Perform near work closer, 2 books per week, read more than 2 hours per day, every book read per week, everything increased the chances of myopia. So practice Pearl is elbow rule, make them keep the forearm distance between the eyes and book, 20-20 rule, take breaks, 2-hour rule, less than 2 hours screen time after school and don't sit for too long. Is it all accommodation? Nobody knows, but check for accommodation lag. Finally, the big monster, digital screen time. We've all been blaming it. But alas, there is really no clear evidence. I was very disappointed as well. But could it be that it's just near work and less outdoor time, and we're just blaming it all on the screens? So once again, just concluding, parental myopia, education, time outdoors, all have very, very strong relationship. Near work, moderate. Light exposure, moderate. Digital screen really is kind of weak there. So I'm going to leave you with 2 myopia risk calculators. One is called the Primo, and the second is the myopia calculator, which comes from the Brian Holden Vision Institute. And please take a picture of this, because this will take you to my folder, which has all the PDFs that I've used for the talk, which also has a Word document with more references. It will take you directly to my folder. And I learned this trick yesterday. I hope it works. All right. Thank you so much once again.
Thank you. I think it's apt that we're starting with the most important thing. I think myopia is a lifestyle disease. And just like diabetes, unless you don't reduce your sugar, no treatment can be successful. So unless you do a lifestyle modification, whether it's near work related, whether it's outdoor exposure, I don't think any of the interventions we're going to talk are really going to be effective. So I think we'll just go on to the next talk and maybe have discussions, and I'm sure there are a lot of questions in the end.
I would now like to invite Dr. Murli to come and speak on pharmacological therapy for myopia, and I think something that we've all been using of late for these cases. Over to you.
So thank you so much for having me as a part of the symposium. Like most diabetics who don't like lifestyle changes and are happy taking a medicine, I think even in myopia, we often are quite happy to look at medication to see if we can control the condition, so to speak. So I'm here to speak about it. I would like to acknowledge my colleagues, Dr. Vidya, Saumya, Vandana, and Amrita, who helped me with some parts of what I'm going to be presenting here. So when we look at managing myopia, largely it has been correcting the mismatch. Either we give glasses or we wait for them to get older and the power to stabilize and then provide a refractive surgery to them. Both of this kind of takes care of what the challenge is. But I think today, looking at Dr. Meenakshi's slide, we know that myopia is a huge problem, progression is a larger problem, and we need to see what can be done to control this progression. So there have been multiple meta-analyses that are done, and a range of interventions have been tried. If you look at it, it varies from as broad as acupuncture to lifestyle changes to medication to a variety of soft contact lenses to even undercorrection that used to be proposed earlier. But most effective interventions as on date continue to be pharmacological interventions, and largely these are muscarinic antagonists like atropine and pyranzepine. Atropine, of course, is the only drug that is available today in India for us. Again, when you look at medicines, a plethora of medicines have been tried. Again, as I mentioned, large number of them have been muscarinic receptor antagonists that have shown to inhibit the developmental myopia in a variety of animal models and also in human studies. Pyranzepine has been shown to reduce myopia, but unfortunately, this is not a product that we have available with us. Clonidine, Yonfacin have all been used in animal models. Again, these have their own innate side effects, so we are a little diffident to use it. Intraocular pressure was shown to be a risk factor. Again, a variety of anti-glaucoma medicines were tried earlier that had neuroprotective effect. And recently, a drug called crositin was actually injected around the eyeball, which showed that it slowed down and had a role play as an anti-myopia agent. It doesn't stop there. 7-methylxanthine has been used. This again has been shown to reduce not just the progression but also axial length elongation over a period of time. This was an interesting paper. I found it interesting because one of the comments on that was saying that, oh, there's been a surprising number of drugs that have been tried. So presently, although in human trials we have only atropine, pyranzepine, and 7-methylxanthine, a variety, look at it, from ketorolac to oral riboflavin to an experimental drug BHV12 have been used. Mechanisms, again, a variety of hypotheses from anti-muscarinic effect, dopaminergic effect to anti-inflammatory effect, a variety of modes in which we've actually used them, from eye drops to medications to injecting them intravitreally and subconjunctivally. Long story short, we seem pretty lost and we are not happy with the options that we have. Atropine has kind of stood the test of time, and again, a variety of mechanisms have been proposed in terms of how atropine works. The primary site is pretty controversial, but recently studies have shown that it probably has a role play right from the dopamine receptors right up till the cornea in terms of how it works. Is it something new? No, it was used by Wells in 1900 to stop by paralyzing accommodation, so that's how old a medicine it is. And the first randomized trial was in 1989. Again, there were other trials done in 1999, but some of these lacked randomization, lacked biometry principles. The atom 1 and 2, by and large, are what we kind of hold the practice of use of atropine today. Atom 1 showed that atropine was well tolerated. Atom 2 showed that 0.01% had minimum side effects and again retained efficacy with minimum rebound. Prior to this, atropine was not commercially available. We actually did a small study where we reconstituted atropine and we used it in children and showed that it was very safe. Why is this important? Today we are looking at the LAMP study that says that higher concentrations of atropine possibly may be required, and when you don't have access to commercial applications, it is not a bad idea to reconstitute it. In our own practice, we have found that using 0.01% atropine twice a day seems to work very well. At max, we've had to use 0.02. As on date, we have probably 2 children who are on 0.05%, so we've not really found the need to use a higher dose of atropine in them. The LAMP, however, showed that there's a dose-dependent response, and 0.05% was the most effective over a period of 1 year. So this, again, has been done in the Eastern Asian population. In our population, again, we probably need to see what happens with it. We've again been tracking some of our children over a period of time, and we found 0.01% to be extremely effective, both in terms of control of spherical equivalent as well as the axial length elongation over a period of time. How difficult is it to use? We've again got some kind of qualitative insights from parents because invariably they're the ones who you need to convince. The child doesn't have much of a choice in what is being put on the eye. So most of the parents in terms of feedback is that there is an initial discomfort and they get used to it quickly. There is some amount of fear mongering that does happen, saying that if you don't do this, your power is going to go up. And some of the older children are, of course, much smarter. They are able to understand and start using these medicines. And still the doctor is important to the child, they do listen to us. Is atropine the know-all? No, there are multicentric studies that have shown that it doesn't work as well in the Caucasian population. This has been seen in UK. This has been seen again in Israel, as well as a part of the PEDIC study. So again, there seems to be some change there. So atropine obviously is not the magic bullet, and patients do find it difficult to use it year on year, and they also have sometimes a challenge in terms of accessing the drops. Putting a drop into the eye because of the preservative again causes stinging. Again, this is a very interesting study from Sunny where they've looked at kind of nebulizing it and spraying it on the eye. We had tried some of these earlier. There are some publications of using it as dilation drops in the OPD. We've not found the dilation drops to be very effective. Again, the absorption, we're not too sure how it's going to work. Again, atropine by itself may not work. You may need to add it in. Like Meenakshi ma'am mentioned, outdoors is important. We found that in children on atropine who are spending time outdoors, there is a definitive additive effect. Again, not just atropine drops, even vitamin D we found to play a role. When you normalize it, or in children who are progressing, invariably the D3 levels are less, and correcting it may have a role. With atropine, start-stop is again something which is anybody's guess. We're still not very clear. Do we stop it at 15? Do we stop it at 21? Do we continue it on? When do you start it? Today we've now started talking of pre-myopes, at-risk population. Do you even start it on them or wait for them till they're older? Levodopa, again, is some interesting studies that are there. Unfortunately, again, this is a molecule not available in our country. This has again been shown in a small placebo-controlled study to actually be effective. It has both inhibited experimental models. It had minimal systemic distribution and did not affect the ocular development. There is one trial that has been published. Hopefully we will see more of this, because if atropine is working on the dopamine mechanism, why not just increase the dopamine availability in the eye? Currently, there obviously is no definitive method to prevent progression or reduce its prevalence. There is a lot of uncertainty, and we need to keep at it, keep sharing information to see how we can find a more appropriate solution to slow down the progression of myopia. Once again, I thank AIOS for making me a part of this session.
Thank you, Dr. Murli, for a very comprehensive talk. Yeah. Dr. Murli, please be part of the panelists here on the dais. So I here invite Dr. Jyoti Matalia for her talk on role of optical therapy in myopia. So we have a plethora of options which are available as an optical therapy, and each with its own pros and cons.
So good afternoon all. So we've been hearing that previously, unlike how you would give glasses for a myopic progression, now we know that there's a significant global prevalence of myopia, and that's why we are looking at various options. We also know by 2050, there are going to be 50% of the population myopic, which means 1 out of 2 is going to be a myope, and about 10% of them going to be having high myopia. Hence, there are these various options that we are looking about, and we've already heard Dr. Kaushik speak about the drops, and Dr. Meenakshi talk about a lifestyle. What I am going to be talking to you are the various optical therapies that we can use in myopia. So let's understand what are the theories that relate to myopic progression. One is the feedback mechanism which causes emetropization, the dopamine low levels and biomechanics issues which can induce axial elongation, accommodation lag, and finally peripheral refraction. So we don't really know what works. It's a multifactorial disease, but what we can look at in terms of optical is the peripheral refraction. So what happens is, if you are looking at the eyes, normally when rays of light are seen centrally, they do focus on the retina. But if you look at the peripheral refraction, you see the refraction is happening beyond the globe. That means there is some amount of hyperopic defocus. And then comes the options of defocus devices, where there's some amount of myopic defocus happening in the periphery, and that may eventually prevent the axial elongation. But before we go on, let us look at what are the then options available. Yes, we have the defocus glasses that we have and the contact lenses. But before moving on to these specific devices, let's look at the various optical treatment options available. Glasses and contact lenses. In glasses, previously it was a single vision with undercorrection or a progressive additive lenses, which is not much used now to prevent the progression. But definitely the defocus and the contrast altering glasses. The contact lenses which could be rigid, that is the ortho K, or the soft bifocal or the multifocal ones. So let's look at the various options which we are going to look at. The DIMS by Hoya, that is a defocus incorporated multiple segments. The Halt technology, the highly aspheric lenslets by Stellis, that is the Stellis glasses by Essilor. The diffusion optic technology, the DOT by Essilor. And cylindrical annular refractive element CARE by Zeiss. So let's look at individual of each of them. So this is basically a particular DIMS glass which has a central clear zone of 9 millimeter for distance refractive correction, and around that you will see about 33 millimeters of 400 multiple defocus segments, each about 1.03 millimeter diameter and having a plus 3.5 millimeter myopic defocus. So this defocus along with the central focus is meant to prevent the axial elongation. Then comes the Halt technology, where you can see that there are basically 11 rings which are of defocus which induce, and if you look here you have the classical volume of myopic defocus which is induced, and that is what this particular technology does, the entire three-dimensional volume of defocus. Then comes the DOC technology. What they do is the central area is going to be clear, that takes care of your central refraction, but peripheral there are multiple dots. What is believed the abnormal contrast between the cones is responsible for axial elongation. These multiple dots create a haze, and that tends to reduce the contrast and thereby will prevent the axial elongation. Finally, we have the CARE by Zeiss, where there are, as you see, multiple cylinders of induce defocus, and these are on the front surface. This defocus and focus is what will prevent the myopic progression. So here we have these four options, of which we can see these are the three which are considered causing the myopic defocus and thereby the defocus glasses, whereas this is the one which modifies the contrast. Now coming to the contact lenses that we are aware of, before that let me tell you that DIMS and Halt is what we have been using, and the technology definitely shows about 60 to 70% slower the myopic progression, and that is more so in the Asian population. We don't really have much studies that talk about the Indian population. That is what we need to look at. Now coming to the contact lenses, we have two options. One is the Ortho-K, that is a night wear contact lenses where the child sleeps with it. That's by Seed or Bosch and Law. So when the patient this is how the cornea is when he wears the lenses prior to sleeping. Entire night wear, minimum about 8 hours, and next morning if you see there's an altered shape of the cornea for which the child need not wear the glasses the whole day, and that is the advantage. Especially if the child does not want contact lenses, that's a good option for the whole, does not want glasses the whole day, he can be without glasses. All he has to do is wear the night wear contact lenses. Then the soft CLs, which is that is called as MySight OcuView. Both of them have the classical treatments which create a myopic defocus and a corrective zone. So both of them are meant to prevent it from going up. So these are the daytime wear contact lenses. Now there are certain specifications we have to know when we are either ordering of these. These are definitely available in India and commonly used. So you should know that the spherical equivalent factor should be about, total spherical equivalent should be not more than -10, and the maximum cylinder is about -4 for the DIMS and the Halt. But in case of Ortho-K, the cylinder is not more than -1.75. So when you're ordering lenses, you need to be aware of the same. So just to know that those are the options which cause myopic defocus are the DIMS, the Halt technology, the CARE, Ortho-K, and the Soft-OK. So these are the ones that are now available, which we can look at. But what we need to understand is there are multiple options, and long-term studies, however, in Indian scenario are not there, and that is what is important. So with this, we have the advantage of the peripheral refraction, and we have studied about 228 eyes on the open field autorefractor. We tried to use it to see whether there is some amount of refraction hyperopic defocus present or not. And we found about 54% of our patients actually had myopic defocus than the hyperopic defocus. And for that, what we further analyzed them in the various sites. That is, we looked at them superior, inferior, nasal 20 degrees, nasal 30 degrees, temporal 20 degrees and 30 degrees. And we found that the more amount of myopic defocus was seen in the nasal quadrant, whereas the hyperopic defocus was more in the temporal quadrant. And then on this basis, we have followed our treatment and given the different line of options. Also to note that the myopic defocus range anywhere from 1.3 average to as high as even 4.62 in those which were progressing. So these are patients who are having myopic progression. And the hyperopic defocus was as high as about 7. So what I would want to say is that depending on this, we have categorized our patients and are looking at options of those with myopic defocus, LDA, defocus glasses as the parents insisted, and some of them refused treatment. So these are a group of patients. And hyperopic defocus, we gave defocus glasses in about 52% of them, Ortho-K in 3, and LGA in 4, and refused treatment in 34. So these are the patients we have distributed. We are hoping to look at our answers because at least you need a year or two for it to know whether this works or not. And probably for the next AIs, we may have a data to really tell from the Indian population how well they do with regards to the peripheral refraction. So thank you very much for a patient listening.
Thank you so much, ma'am. I think we get to the last talk of this particular session. My privilege to invite Dr. Jitendra Jetani to speak about the complex issues of myopia management. The first 3 talks would have confused you a little bit. I think now we are here to overwhelm you a little bit more.
I think my talk will confuse it further because I think one of this, I'll just start with the slide. So I think this is one of the slides which we see most in, this is a slide to scare everybody that, myopic epidemic, pandemic is going to come, the sky is going to fall. And this is the Indian scenario. Why I am talking about this is the data. 2 of the articles are by Dr. Rohit Saxena. And this was part of my PhD thesis, part 1. So what are the complex issues in myopia? One of the most important point in myopia is not just myopia. We talk about myopia. Myopia is very simple. Myopia is very simple, very easy to diagnose, and very easy to treat. So most of the ophthalmologists were doing it over a period of almost 200 years. Now the complexity arises. The first and foremost part which makes this complex is understanding the progression. Who will progress? That is the crux of what makes it complex. Who is going to progress? Which patients are going to progress? The peripheral refraction which Jyoti showed, so there were bulk of the patients who were actually having myopic defocus and yet they progressed. And then there were hyperopic defocus patients who progressed. So whether we should be doing peripheral refraction or not, we have no idea. Who will progress? That is the one most important thing. Second are different types of myopia. So whenever we are treating myopia, we should understand that this particular patient has an axial progression and we all have modalities to treat only axial progression. So the point which I am trying to make is about axial progression. Third is pre-myopia. So if you can have a set of points, if you can have a set of questions or set of diagnosis documents which can tell you that this particular patient is going to progress in future, you can actually prevent or stop myopia at a very, very lower level. That would be very, very important. And all of this will also help us in our patients of pediatric cataracts that we operate, pseudophakic patients, they also go into a myopic shift. So bulk of our patients whom we operate less than 2 years of age would go for myopic shift despite the fact that we have removed the lens. So accommodation has got absolutely no role, at least in pseudophakic patients, in those pseudophakic patients, and what to do when you treat them and they are still progressing. So this all has been discussed in most of our lectures. Why myopia progress? Maybe genetics, dopamine, near work, outdoor activities, myopic defocus. And so, this is about genetics. So the risk of myopia increases. We saw Meenakshi madam presented that it increases if one of the patient is myope. So these are all risk of myopia or risk of progression. Now, these are 2 different things. So you can have myopia, but progression may get affected by it or progression may not get affected by it. So the key message is that if parents have myopia, kids are more likely to have it. They are more difficult to treat. When you give them atropine, they are more resistant and they are more prone to be non-responders. Outdoor activity always makes a huge difference, as Dr. Rohit mentioned that, the bulk of our practice should be to tell the patients that outdoor activity and near work amount of light makes a huge difference. And this was published from the Singapore article. Height increase does correlate with the growth of size of eyeball, and it occurs 2 years before the height spurt. So myopia in premature kids, this is totally different from the normal school-going myopia that we encounter. One of the articles which showed that the incidence of myopia was 14.3%. This was an Indian study published by Savleen and Jasprit. So this was very interesting. You see, at baseline, infants with ROP had an overall comparable axial length. So there was no axial elongation, there was no problem. At 1 year, children who were treated with laser had shortest axial lengths and least decrease in keratometry. So it is because the cornea did not become flat, and so they mainly have curvatural myopia. And that is very, very important when we are sitting in myopia clinic or when we are sitting in our pediatric ophthalm and we have a patient, we have to do K reading, we have to do axial length to find out what is causing the myopia. We don't have to just start a myopia, myopia control treatment because there is no myopic progression. We have to first see whether it is a curvature myopia or not. Good old things, but it just holds today also. A lot of patients we all see where patients are premature and they have been given atropine for nothing. Their myopia is completely at a different route, different plan has to be followed there. So this is something which we do in our clinic, and we have seen that normally this myopia almost stops by 5 to 6 years of age. Yeah, another complex issue in myopia is the curious case of pre-myopia. So who is a pre-myope? Whether plus 0.75 diopter is a pre-myope or he is a hypermetrope actually. So if there are risk factors, if you have serial axial length elongation when patient was plus 0.75, parents are myopic and there's a lot of near work and you have done axial length and axial length is elongating and his refraction is actually going down, then you can label them as pre-myopes. But otherwise, talking about patients who have plus 0.5 and talking about them having myopia would be a serious, crossover. So this was something which we published. So what next? There's a lot of work to be done on with newer publications on atropine 0.01% not being very effective in long term. We have to work more on concentrations, more work on pre-myopes exactly with bigger sample size, more work on risk factors and identify who will progress. This is very, very important. More work on pharmacological agents, and I think a lot of work should be done on myopia calculators to predict what and who will be progressing. So we all know myopia prevalence is on rise since last 2 decades. We are more interested in who will be progressing. Near work, screen time, low outdoor, these are all risk factors. So we need more combat strategies, more ways to find out who is going to progress and treat them. So thank you so much for the opportunity. Thank you.
Thank you, Jitendra, for an excellent presentation. I mean, we've gone through all the talks. If there are 1 or 2 questions we could take, and then we'll hand over the hall to the next session. Any questions? Yes, Jiten. Mike. उस पे चले जाओ.
So in those with the myopic defocus and hyperopic defocus, did you measure the choroidal thickness in those myopes? Okay. Well, that would be interesting. I mean, what is the choroidal thickness in both these conditions? Because a lot of interest is being generated that it's the choroid which is basically the seat of myopia.
So the choroidal thickness is probably a separate independent risk factor that is being considered, and the change of choroidal thickness is being considered as a factor that may help to predict progression versus none. But again, how it relates with peripheral hyperopia is again something we don't know.
So we have a poster with Dr. Amit on choroidal thickness, and we found that choroidal thickness actually decreases as the axial length progresses. Now the most important factor is not that, it is already well documented. The point is whether it is choroidal thickness, choroidal thinning, which is a precursor to axial elongation, or it is the axial elongation which is causing choroidal thinning. So till the point these 2 things are not found out, the point of choroidal thinning is of no value. And most important, whether we can treat that choroidal thinning at an early age. The problem is that the softwares of measuring choroidal thickness are not very robust. True. So
there is
we
still
really
that,
don't know what we are doing.
Exactly. So that large variability that still exists in measuring a test-retest variability of the instruments that we have. So that is why, as of now, I think that's why all these are coming out with equivocal results. So that's what, Dr. Reena, you had a couple of points to make.
So can I ask a question?
Yeah,
so
sure.
My question is regarding the atropine eye drops. So we talk a lot about atropine eye drops these days, but there are no clear directions to when do we start, from like what level of myopia do we start the atropine eye drops, and do we need to give a halt after using it for some weeks or some months, and how do we actually judge that is it working? in the progression?
So I think we'll just quickly, I mean, a lot of this has been actually discussed. As Jiten said, you need to confirm that myopia is progressing irrespective of the baseline myopia the child has come with. So you need to document that the myopia is progressing at whatever rate, which means a follow-up, or which means going through the records and identifying that there is a rate of progression or a rate of change of glasses. So that is first, you need to make sure that you're not treating myopia, but you're treating progressive myopia. Myopia is treated with spectacles or any refractive correction. Progressive myopia requires the interventions we have discussed. How long we are going to treat, that's something we still don't know. There are no clear answers to it. We know that nowadays we are finding children starting glasses at a much younger age. There is adequate data available for up to 5 years of atropine use, and generally everybody is talking about that sooner or later you have to start your tapering and stopping atropine. So our plan usually is you start a treatment, you follow it up. Once the progression stabilizes, then you can think of tapering a drop or think of weaning them off the glasses, and then follow them up again for rebound or if it restarts. So that's a follow-up that you have to do, and I think a lot of questions are still being answered, and we'll get to know as we go along.
What is the panel's opinion regarding progression of myopia after adulthood?
So we're seeing
So what
this
do we do
post-COVID.
Yes,
Again, in
post-COVID,
pathological myopia, there's not much that can be done. But post-COVID, we do see children who are now young adults progress until 21. So that's a trend that we are seeing more and more in clinic. And to the earlier question, I think thumb rule clinically, I think what most of us end up doing is put them on medicines for about 2 years, pause and see what's happening. But before you start them on the drop, see if lifestyle can be inculcated. Because once you start them on medicine, the tendency to go outdoors or to correct their vitamin D levels goes out of the window. So it's always good to get those habits in place before you start the children on medicine. But yeah, post-COVID we're seeing until 21.
Yeah,
so
but
that's something
what everybody is doing, I would like to get panel's opinion regarding that.
For the adults also, I think it's primarily related to the lifestyle aspect of it. So that's the most important thing that we can change, because we're not at that stage anticipating growth further. So that's what I normally advise them, is to make a change in their lifestyle and to spend time outdoors in sports. And I think with a lot of the Netflix and all of this stuff happening, near activities have kind of become, almost all days on that now.
Atropine also seems to work in some of these people, ma'am. So I have a few children on it. It does slow down progression even in much older children.
So just want to add that when you're talking about stopping or atropine after 1 to 2 years, you have to not only look at the refraction being stable, but also the axial length. So that also stabilizes. Also watch if that child is going to be within the growth spurt at the age around puberty, because then in that case we cannot take off. We may need to still observe before we decide to take. Otherwise there'll be a sudden spurt. So there are multiple factors that you will look for when you decide to either take off the atropine.
Yeah, I just want to add from here that in patients with high myopia, now does the dose of atropine we are using, does it work? And what about the combination therapy, Dr. Rohit?
So we still are trying on high myopes and all. The studies haven't included high myopia, but I'm sure a lot of us have anecdotal experience that it is working outside the tested ranges. So younger and older adults, as we discussed, same for high myopia also. So we are observing an effect, and I think as data gets collected, we'll get to know how the efficacy changes with age and with the severity of the myope. So I think, thank you everybody. It's been very interesting. We'll hand over to the next chairpersons. I think they're already there, Dr. Rashmin and Dr. Naveen Jaikumar, Dr. Swati, Dr. Ambika, Dr. Sachin I think is also here. So may please come up. In the meantime, we'll take a quick photograph with the speakers.